Hello, everyone, and welcome. Thank you for joining our 2025 Patient Education Forum. My name is Laura Garman, Education Manager at the Cutaneous Lymphoma Foundation. We are pleased to have you all with us here today. Before we get started, I wanted to go over some housekeeping for today's event. To enter in questions during the Q&A portion or during the presentation, please use the Q&A feature that you'll see on the bottom of the Zoom. The chat itself will not be available. Also, due to time constraints and the number of questions we may receive, we may not be able to address all of them during this forum. Additionally, please keep all questions asked general. The physicians are not able to give specific advice to cases. The program will be available to view on the Cutaneous Lymphoma YouTube channel in the coming days. And I do want to mention there will be a 5-minute break built in during tonight's presentation. I would like to thank our individual donors and our funding partners for making this program possible. We can't do it without their support. This is how we're able to produce forums, educational programs, webinars, and other materials, so thank you. And now it is my pleasure to introduce our moderator and one of our presenters for the program, Dr. Youn Kim. Dr. Kim is a professor of dermatology and member of the Stanford Cancer Institute. She is the director of Stanford's multidisciplinary cutaneous lymphoma program. Her current research is dedicated towards strengthening the collaborative interface for novel discoveries and exploring new and improved therapies with tumor-specific targets and enhanced potency. She and her multidisciplinary colleagues are exploring various novel cell therapy modalities. Dr. Kim, thank you so much for being here today. I'm so pleased to turn the program over to you.
And here's the last slide for the CLF. Thank you so much, Laura. I want to thank everyone for joining, and it's such an honor and privilege to represent the academic group. And this year it's the Stanford Multidisciplinary Group in this patient education session. We're very excited to do today's event, and hopefully we'll get to learn more about each other's needs as we move along. So in the program, we have structured so that we start. I'm going to introduce our multidisciplinary team. It was too kind of Laura and CLF to introduce me, but it's all about the team. I support the team, and we'll introduce the team. Then our wonderful colleague, Dr. Erica Wang, will go over mycosis fungoides and Sézary syndrome diagnosis and management. And then we'll have a 20-minute QA afterwards. And then Dr. Jennifer Wang will go over CD30 T-cell lymphoproliferative disorder and cutaneous B-cell lymphoma. And we'll have a QA following that, so you can ask those questions. And then we will have a short bio break. So there will be a 5-minute bio break. And then we'll go deep dive into the research advances where you can hear about the new therapies. There were a lot of questions about new therapies. And so it will be exciting to present that. And I'm going to show you how the clinical trial, the phases are run, and Dr. Khodadoust will deliver the meat of the new therapies and tools that are exciting in the future. And then we'll wrap up with a 30-minute general Q&A, and you can ask anything you like in any of the sessions, and then we'll kind of finish it up with a 30-minute QA at the end. So hopefully that will work for you. This is our multidisciplinary program. Obviously the pictures are really old. So like this is me 25 years ago, but hopefully, and Michael is I'm dermatology, cutaneous oncology. And then Michael, who's the co-leader, is the medical oncologist. And then Richard Hoppy is the radiation oncologist in the group. And then Wang is a cell therapy. So in lymphoma, skin, medical oncology, radiation, and cellular therapies are very key to helping the patient as a whole. And then what is lacking here is like, we don't see, not lacking or missing is like surgical oncology, which may be more appropriate for solid tumors. But for hematolymphoid malignancies, it's these 4 disciplines that are key. And in the dermatology would include like pathologists involved in the diagnosis. So then additional members that are strengthening the team. So again, it's a team building. Dr. Jennifer Wang is a cutaneous oncologist, dermatologist that has joined our program, also does dermato-oncology and melanoma. And Dr. Erica Wang also joined, and she was one of our fellows. And she's also partnering in our cutaneous lymphoma and also does melanoma work. Then we have 2 additional members in radiation oncology. That includes Dr. Michael Binkley and Susie Hineker, who has a focus on pediatric radiation oncology. And this makes the radiation oncology team right here. Very good looking. And then the rest of our team members, as you can see, we have clinical research, and that includes a translational component, clinics to the lab and back, and our clinical research staff and clinical trials and research, and our clinical staff who helps us to ensure that patients are safe and well managed. So now I'm going to hand it over to Dr. Erica Wang, and I'm going to do a short handover of the slides. And then we'll come back to the QA. Oops. So Erica, please share. Got it?
Perfect. Okay.
Got it. I see it.
Okay, thank you so much. So thanks, Dr. Kim. So I'll be starting off this session with talking about mycosis fungoides and Sézary syndrome, mainly focusing on diagnosis and treatment. So what is mycosis fungoides? And so it is when cancerous T cells, which make up part of your immune system, starts to invade your skin. Your immune system is really important. It keeps you healthy from anything foreign, and it's made out of T cells and B cells. And most cutaneous lymphomas, about 50%, are T cell in origin. What causes it? We really don't know, but we know that it is not contagious, so you can't spread it to anyone. And it's not very hereditary, so we don't see it passing down in many families from mother to child, etc. What does it look like? So there's a variety of presentations. It can look like different things in different people. So it could be, for example, this is one of my patients with it's just a single patch, or single pink or red, scaly patch or rash. It could be thicker, and it could be what we call a plaque. It could be multiple patches or multiple plaques, like you see on this leg, where you can kind of see different areas of redness on the front, on the back, and the sides. And it can, involve any different areas, not only just legs, but it could be arm, it could be chest, it could be back, etc. It could be light colored, especially in patients who are darker skin types. It might not necessarily show up as a pink or a red rash. It might be more white in color, and it might be more contrasting to their kind of background skin color. You can also have more darker, what we call hyperpigmented patches, where you can kind of see in this shoulder here, where there's kind of these circle areas of darker rashes on the front, back, and then chest and the arm. You can even have it where some patients are covered head to toe. More than 80% of their body is covered in a red rash, which we call erythroderma. And lastly, you can have tumors, which is nodules or growths, like kind of really thick areas of ball, like a lump in the skin. And sometimes these lumps can even break down, erode, the skin can break down, and it can kind of open up into a sore. So who gets it? It's very, very rare. It's probably 1 in 500,000. It's very unusual, not seen very many times. But it's most common, the average person who gets it usually are older. They're in like their mid 50s, 60s, 70s. Males are more likely 2 times more than females to get it, but really it can happen in all races, all skin colors, all ages. We definitely have our fair share of patients, ranging from young children all the way to patients who are 90 years old and above, and all ethnicities, all races, and definitely all skin colors. Sézary syndrome is very similar, but a little different. And what this is it's the leukemic version. That's how we describe it, where basically the abnormal lymphoma T cells, instead of just in the skin, they also can be found in the blood. And so what does this look like? Usually the diagnosis is made by 3 things. One, most patients are erythrodermic, meaning that, again, that rash is covering 80% of their body. They usually have some big lymph nodes when they come in, and usually you can find the cancerous T cells in their blood and what we call Sézary cells. And these Sézary cells, you can see a picture of them there compared to red blood cells surrounding it. They tend to be kind of these large, abnormal kind of shaped T cells that can be found in the blood. More to diagnose Sézary syndrome, there has to be more than 1,000 cells in the blood, and we have to find something called a T cell clone. So more on what is a T cell clone. So your immune system can actually recognize an unlimited set of antigens or foreign particles in your environment. And how does it do this? It's because they have receptors or antigen receptors on their surface that are very unique to that cell. It's kind of almost like a lock and key mechanism. And how to create that kind of diversity, right? Your immune system has to protect you from bacteria and fungus and parasites and the common thing like cats and dogs, etc. And how does it do all of that? It's because it rearranges these different genes called V, D, and J. So V variable, D diversity, and J joining. And by kind of mixing and matching, you can get unlimited combinations that allow you to recognize different things in your environment. So for example, these are 3 different T cells, right? By combining the different genes, like we saw, these 3 different T cells have different receptors on their surface. So the one on the left might recognize, let's say, dust mites, which I'm allergic to. The one on the right might recognize, let's say, COVID or the flu virus. And the one in the middle, maybe the cancerous T cell that we see in MF or Sézary. And so when these T cells make more of themselves, each of them will have the same barcode that the original T cell had. So you can see here, all of them recognize different things. They all have different, let's say, barcodes is the easiest way to say it. And so what happens is when you take all the sample of T cells from the skin or the blood and run it through this machine, what you can see is you can pick out that specific T cell. And in this case, you can see that clone, that one bad T cell, that lymphoma cell, is really skyrocketing high compared to everything else. And that's kind of the results you would get when you were to if you were to biopsy the rash of MF or check someone's blood who has Sézary syndrome. So this gets to how do we diagnose MF and Sézary? First of all, we look at the skin. So the skin exam is really important. MF tends to love very sun-protected areas. So hips, butts, skin folds, just like this gentleman here. Other things we look at is we look at lymph node exam. We check for those big, bulky lymph nodes in the armpit, in the neck, in the groin. Another thing we look at, of course, is like we mentioned, skin biopsies. Skin biopsies are very key to making the diagnosis of MF because MF can look like other things like eczema, psoriasis, more common things than MF. And sometimes the skin biopsy, honestly, isn't that impressive at the beginning. And so it might require multiple biopsies at once. You might need to even repeat the biopsies in the future to get the diagnosis because that first biopsy might not be revealing enough. What we're looking for on the biopsy, we're looking for a specific pattern that mycosis fungoides and Sézary has. So we're looking for these abnormal immune system cells, lymphocytes. They look funky compared to the normal normal immune system cells we see that are normally in your skin. They're a little bit funny shape. They have a weird center. So they just don't look the same as the others. We're also looking for something called epidermotropism, where those abnormal lymphocytes are actually they like to live in that top layer of the skin. So they're kind of going from underneath the skin into the top layers. And that's kind of a pattern that MF likes to do. Other features, what's nice about skin biopsies is we can really look at those lymphoma cells and see where they like to live. Are they only in the skin, or do they have something what we call follicular tropism, which means that they like to live in the hair follicles? Sometimes this can cause things like baldness in the area or acne in the area that you have your MF. We also look for something called syringotropism, which means that these lymphoma cells are attacking the sweat glands in the skin biopsy. Sometimes some people have something called large cell transformation, which instead of these lymphoma cells being small to medium in size, they're actually very large. They're 4 times the size of a normal immune system cell, and there's more than 25% of them in the whole biopsy. Other things we can do is that clonality test that I was talking about, looking for that specific barcode in your MF and Sézary. We can either do it on the skin biopsy, we can do it in the blood, and the results will show you something like this, where you can see those, it'll come back as positive, and it'll show you that like sky abnormal 2 clones in the skin just not matching the rest. Same thing with the blood. We can look and we can do special testing in the blood, what's called a flow cytometry or a Sézary count, and look for those abnormal lymphocytes. And in our particular test at Stanford, we see something and it'll give us a result like this, where it will say atypical lymphocytes present. And in those cases, it'll usually give us a number as well. And then we can also send the blood again for that same T cell clonality. And if you see matching T cell clonality in blood, in skin, in multiple skin biopsies, that's something that happens in MF and Sézary and doesn't usually happen in things like eczema, psoriasis, etc. Other things we sometimes do is sometimes we look for scans. We do imaging. So whether that's a PET CT or a CAT scan of the body, we're really checking for the lymph nodes. Sometimes the lymph nodes are harder to reach. Sometimes we can't feel everything with our hands. And we definitely can't feel internal organs, right? Liver, kidneys, etc., and lungs, for example. So the PET CT allows us to look inside the body to see if there's anything abnormal. So in this example, in this imaging scan of a patient, I've circled in red the different lymph nodes that were brighter and bigger than normal. And so this person did have their MF involving their lymph nodes in their neck, in their armpits, and in their groin. Lastly, sometimes we can do genetic testing on the skin biopsy, on the blood, on the lymph node, to looking for certain mutations. And the mutations can potentially give you some potential targets for certain treatments that are available. Sometimes the mutations can just help you decide what type of cutaneous lymphoma you may have, because there's so many different types. There's certain mutations that we see more in mycosis fungoides versus Sézary versus other T-cell lymphomas. But overall, you kind of look at everything. This is the whole picture to really get the diagnosis of MF or Sézary. And sometimes this process takes a while. Sometimes from that first rash to diagnosis can be on the order of many years. Sometimes it's many biopsies as well. So just keep pushing and keep, seeing your doctors for reevaluation if something's not going away. So what's the staging for MF and Sézary? Being a cancer, we use this classification system, like all other cancers, that breaks it down to 4 different categories. There's T for the skin, tumors, lymph nodes, N, M is metastasis, and B is blood. So T in the skin, what we're looking at is, again, patches versus plaques. Is it less than 10%? Is it more than 10%? Are there tumors, which would be a T3? Or is it that erythroderma where your whole body is covered in rash, which would get you to a T4? Lymph nodes, right? N0 means that there's no lymph nodes that we're worried about. Anything from N1 to N3, something's on the PET CT, and that we have to investigate and biopsy to figure out. M, metastasis, sometimes MF can involve liver, lungs. It's pretty rare, brain, etc. But that is something we look at as well on the scans. And blood, we check to see how much blood or if there's no blood involvement at all. But you can see B2 is anything above 1,000, like we talked about. So a very, very simplified version. So you take the TNMB scores, the 4 different scores, and you can basically translate it or convert it into a stage. And so stage 1 is basically you have skin only, very limited, less than 10% of your body is covered in patches or plaques, or both. 1B is when the patches and plaques are over 10% of your body. 2A is when you're starting to get that mild lymphadenopathy where it's considered N1. 2B is when you start to have tumors. Stage 3 is usually erythrodermic, so you're covered in rash. And then stage 4 is broken down to stage 4A1 is when you have Sézary disease. So you have leukemic blood disease greater than 1,000. 4A2 means you have lymph node disease. So usually that N3 there. And lastly, 4B is when you have organ involvement. So for example, like your liver. Again, it's very simplified. There's more details to it, but this is kind of the bigger picture of what the staging looks like. So treatment, how is treatment done? So it's really based on stage. It's based on your specific MF, how it behaves in Sézary, and how it responds to treatment. So it's often a balance between effectiveness and side effects, because we're really looking to improve everyone's quality of life, obviously improve their MF and Sézary to make it less, but we know that none of this is a cure. So we don't want to harm anyone and give them any major dangerous side effects. So there are national guidelines given by the National Comprehensive Cancer Network every year, multiple times a year, and MF and Sézary are both included in the primary cutaneous lymphomas. And so I'll go over a few of those treatments that are listed there, and definitely the ones that we love and use at Stanford. But again, the following is not an exhaustive list of everything available, which is great because you'll see there's so many treatments available. And it really depends on the person and the patient. So for example, stage 1 is one of the first line treatments are usually things like topical steroid creams, nitrogen mustard or methchloramine. Bexarotene gel is FDA approved for MF. We can even do things like phototherapy, which is very mild, has many limited side effects only to the skin only, so irritation, sunburn, etc. And we can combine some of these too, right? We can do topical steroids and phototherapy at the same time. If there's a bothersome spot, we can always radiate that spot, just that one spot or a few spots, etc. So these are usually the things we do for early stage. Once things get a little bit more widespread, that's when we start thinking about maybe, if someone's tried phototherapy and it's just not enough, maybe after a while it stops working or anything like that, then maybe we might want to go on to things like oral pills, things like oral bexarotene, which is a vitamin A pill, a retinoid, what we call, or things like methotrexate, another pill. But again, what you choose, really, the provider is probably thinking what would be a best fit for what stage you're at, where you have disease, how much you have of it, how much MF you have, and honestly, your particular situation in terms of what other medical conditions you have. For example, someone who has a lot of kidney disease wouldn't be a good fit for something like methotrexate because methotrexate goes through the kidneys to get out of the body. So things like that. If for stage 2B, which is again tumors, you have some great treatments like brentuximab, which is an antibody against CD30, which is a marker on the lymphoma cells. Other things like total skin electron beam therapy, which is kind of whole body radiation at low doses that works really, really well. When you're at stage 3, which is that erythrodermic, more than 80% of your body, then those same things apply, but maybe you're looking more at infusion treatments, such as things like mogamulizumab, which is an antibody against CCR4, or things like extracorporeal photopheresis or romidepsin, or just oral methotrexate and bexarotene might be enough. So again, it depends. And then lastly, with stage 4, we're really looking at systemic treatments, and here you'll see some new things. So for example, mogamulizumab, that antibody against CCR4, and romidepsin are great for blood disease. But if you have more lymph nodes are involved, and that's a bigger problem, then maybe romidepsin or brentuximab or pralatrexate, which is methotrexate, but in an IV form, might be a better choice. You'll see some single agent chemotherapies like gemcitabine, doxorubicin, etc. Some immunotherapy like pembrolizumab. We don't do a lot of chemotherapy because there's a lot of side effects with multiple chemotherapies, and we know that it doesn't cure. There's a lot of great clinical trials out there, including here at Stanford, and then sometimes we even do things like stem cell transplant if someone has gone through many treatments and their MF or Sézary is very aggressive. So again, the point of all of this is to say there's so many options, there's so much hope, there's so much promise. If one thing, we can always start with one thing, and if that doesn't work, we can always try another one. But really, it should be an individualized, very personalized approach because it's not a one-size-fits-all for everyone. There's so many options out there. What works for one person might not be the best choice for the next person. So last thing, how do you know if treatment is working is a common thing that I get asked. So one, we look at a lot of the different things. So one is we use a lot of skin exams, of course. We use a lot of comparison of photos. And so you can see the drastic improvement this one patient had where he's erythrodermic before and now his skin is completely clear and normal, right? And that's the kind of response or improvement we want to see. Sometimes we'll definitely check blood tests, that flow cytometry, if someone's has a Sézary syndrome, where we can count, right? The test at the beginning for this patient of mine started at 3,200 Sézary cells, but with treatment, we got it down to 0 and it stayed at 0. So those are kind of the best case scenarios we're looking for. We can actually do something called minimal residual disease. This is something very specific to Stanford, where even let's say for this patient where the flow cytometry is saying there is 0 lymphoma cells that we can detect, we can use the clonality tests that I talked about, where it just spits out positive or negative as a result. But what we can ask them to do is see how many DNA, like T cells, can you see? And this is very, very sensitive and specific. And it can, really track it over time. And really, we love when we see that number go down to 0. That's even better. Other things, of course, PET-CT, if the lymph nodes are involved, then we want to see them go away or at least go back to background noise. And other things, in our patients who have MF and Sézary, they often have a lot of infections. So we always are on the lookout for, things like shingles, which is a virus, fungus, right? Sometimes some of our patients get things like athlete's foot, common things. Sometimes it's bacterial infections when they scratch their skin and create open sores. All of those things can happen. And the other thing, of course, we pay attention to is their quality of life. Itching can affect a lot of patients. It affects their sleep, it affects their work, it affects their activities, their mood. And so there's a lot of anti-itch treatments that we'll do on top of this to support patients. So the main points that I want to say is, the diagnosis can be challenging. It might take multiple visits to the doctors, multiple biopsies, a lot of other tests, sometimes molecular genetic testing. The treatment is very personalized to the person. No one's the same. No one's MF is the same. So we really look at who they are and what makes the most sense. We always recommend seeing a multidisciplinary team with expertise in MF and Sézary. And our team, for example, is made up of dermatology, dermatopathology, medical oncology, radiation oncology, and bone marrow transplant. And I just want to give you guys a lot of hope that there's a lot of great treatments out there, a lot of great ways to diagnose this, and even more coming on the horizon. I'll turn it back over to Youn.
Thank you so much, Dr. Wang. That was incredible. It's so hard to cram such a big topic into 30 minutes. And I know audience has a lot of questions, and I'm so grateful for the very enthusiastic questions. Now, I responded that there are very sophisticated questions, like questions on cell-free DNA even came through. And Dr. Khodadoust actually at the end is going to talk about some newer methodologies for tracking disease. So if you can just hold until then. And it looks like a lot of patients are on phototherapy for control of early stage. Dr. Wang, and please type in your questions to the QA. While you're typing in, I wanted to see, how do you judge phototherapy response in a patch plaque disease, and how do you taper off and manage? Do you maintain, or if you can give us your advice on phototherapy?
Yeah, in general, I think phototherapy is wonderful. I think it's effective. I really think about phototherapy for the patient who has kind of a lot of areas to treat that is just not practical for them to apply a lot of topical steroids or creams on. Phototherapy is great. It is a time commitment. So I tell patients, you're committing to 3 times a week at either a home unit or an office. So definitely you want to be near a phototherapy center. Most times I tell people it takes about 6 months at least to see a difference. So you're really committing to 6 to 9 months for treatment. Once you're clear, I start to taper to about twice a week for a few months and then once a week for a few months. And then if they remain clear, then we can give their skin a break and of course their schedule break as well. So I think most people, and then we can always use phototherapy again in the future.
Yeah, some additional questions on phototherapy. When do you think is appropriate situation, and do you combine it with maybe some systemic therapies in advanced stage patients?
Yeah, great question. I think, I definitely do it for my stage 1Bs where they have more than that at 10% body surface area, or maybe thicker plaques, things like that. You can definitely combine it with other treatments, but again, some of those treatments, if you were to use it with, let's say, vitamin A pill, bexarotene, retinoids, or methotrexate, you just want to make sure it doesn't cause more sensitivity to the light, and so more irritation, more sunburns, etc.
And this is a perfect question for you, since you're also an expert in melanoma and other skin cancers. Questions about phototherapy and concern of skin cancers and in patients who have skin cancer. What is your advice?
Yeah, I think in general, the studies have shown, and I think most of these studies are not specific to lymphoma patients because, again, they're so rare. But in our studies of patients who do phototherapy for psoriasis and eczema, which is the most common rashes you'll see, they've done phototherapy for up to 2 years and found that there's no increase in skin cancers compared to the general population. That being said, it is still ultraviolet light, so I'm a very big fan of taking breaks when your skin is clear and not using it kind of open-ended for 5-10 years at a time. It's always great to give your skin a rest, especially a lot of my patients come back tanned, looking like they went to Hawaii or Europe. So a lot of my patients want to kind of go back to their natural skin color as well.
Great. And in that regard, just want to add that, and please, other members of our group, please chime in, because there are a lot of questions on phototherapy. And it's a great treatment, and hopefully can be. And there is a treatment that is going through FDA approval right now that's not ultraviolet light, but you may have heard of it, Hypericin. It's called Hybright, where you use fluorescent light bulb and a photodynamic, like photo UV, fluorescent light accentuating topical, like a paint, which removes patients from the photo damage. So it may be a potential good treatment in the future that could do without the ultraviolet damage. But we do combine it with interferon. There was a question about combining interferon or retinoids, as Dr. Wang mentioned. Either any of the retinoids can be combined with ultraviolet light therapy, depending on the need. If you don't need it, obviously you don't. And maybe in terms about Sézary, maybe treatment approaches. Oh, there's a good question before we go to that. There was a question about, I think it's more regarding staging. Can you go from stage 2, like higher stage, to lower stage? You want to address that, Dr. Wang?
Yeah, good question. You can definitely improve, but the staging won't change. And this is true of whether or not like you have other cancers, let's say like melanoma, for example. But yes, once you are stage 2, you can go up in stage, let's say stage 4, but we usually don't have you go back down in stage. But that being said, someone who has, let's say, stage 1B or is erythrodermic, right? Full body rash, their skin can definitely clear, but we wouldn't say that they're stage 0 or stage 1.
Great. And there a question that was sent in before, some patients asking great question, if you treat the skin disease well, or can you prevent it from advancing to worse stage, like getting blood involvement, prevent it, like if you control the skin? You want to
Yeah.
comment on that?
Yeah, I'll comment first, but Dr. Kim, please feel free to chime in. Our thoughts are yes, it is always great once you have that diagnosis to maintain it, manage it. We have a lot of great treatments. We can definitely keep it minimal. We never say spotless. And the idea is that the less skin lymphoma you have, obviously, the better. That being said, sometimes things do get evolved, things change, and that's why we do see our patients often and keep up with them because sometimes things happen even though they're kind of, doing all the right things. What?
There's some questions about supportive care. So for the light therapy, there were some questions about what topical support you can do for dry skin, if you have recommendations, or like for itching. There was at least actually a very sophisticated question that came in about biologics like nemolizumab that can help itch in Sézary patients. Maybe some comment about skin support or itch support, supportive care.
Yeah, itch is so important. And it's I would say the number one um, thing that a lot of people complain about, which is very real because it affects their day-to-day life. So yes, topicals, we use a lot of topical steroids, which also helps treat the lymphoma, but also can help with any skin breakdown, things like that. We're fans of things like if you have open wounds, things like mupirocin, which is topical antibiotic. Maybe even if you have a lot of bacteria, overgrowth, then multiple infections, you might want to do things like dilute bleach soaks. That'll help reduce the amount of bacteria on your skin. A lot of moisturizer is important. Staying kind of your skin less flaky is great. So yeah.
Okay. I think there were some questions about CD30 entities, and maybe we could save those for until Dr.
Yeah.
Jennifer Wang talks about the CD30 entities, and maybe come back to some of that, because there was a question about how do you distinguish LYP and MF. Maybe Jen could,
yeah.
you couldn't
I think
comment
that's
now,
Jen.
and Jen
Yeah.
could handle it later. But a lot of good treatments coming out in the CD30 as Dr. Wang presented. And let's see, questions about when do you use Accutane? Maybe your thoughts about Accutane use in MF?
Yeah, Accutane, I think bexarotene does have a lot of, I would say, more effect on the thyroid and the cholesterol levels than Accutane would. Accutane is very well known because we use it a lot to treat acne patients in our younger folks. So we know it's very safe outside of being pregnant on it. So I like Accutane for my younger folks because I think it lasts less as long as bexarotene, has less of that cholesterol, thyroid things. And so if someone has a lot of cholesterol or thyroid issues coming in, then maybe Accutane is a good start too.
Yeah, I tend to love Accutane for the follicular tropic patients, although there's not the data. Bottom line, if there's questions on which retinoid to use, Accutane, acitretin, bexarotene, the bexarotene has lipid, thyroid is very complicated management. So patient needs to be aware you'll be on like 3 drugs to be on bexarotene. Acitretin, I think we say because it's a metabolite, like stays within your body for a long time. And women with childbearing age, we tend to avoid, but great treatment for skin cancer protection, chemo prevention, correct? Dr. Wang?
Exactly,
Yeah.
exactly. So I think it depends. I think situation. I love Accutane for my younger folks, maybe who also have acne, acitretin, like you mentioned, maybe my
Nice.
sun damage patients who have a lot of skin cancers. You get kind of a double effect there. And bexarotene is just really standard for MF. Works really great, but yeah, you are committing to yourself to a cholesterol medicine and a thyroid medicine as well. So it all comes together.
Some questions on retreatment. I'm very sophisticated participants. So I think we have questions about patients who are on brentuximab. Can they get retreated down the road in terms of monitoring effects of side effects and retreatment use?
Yeah, I think here at Stanford, all of us are a fan of retreatments. There's a lot of great drugs. They worked well once, they can definitely work well again. I think it's just monitoring for a lot of the side effects. So for example, brentuximab, the well-known famous side effect of brentuximab is the neuropathy or the numbness and tingling that you get in your fingers and toes that can be permanent if you do it for too long. So you definitely want to monitor that with retreatment if that happens. So just specific brentuximab, but
I love this interaction with my own teammate, Dr. Wang, on the Zoom.
I learned
I'm
everything
loving
from
this.
you, so
No,
I hope
I'm
I'm
loving
saying
this
what you.
interaction. No, but actually, I think another thing is that Dr. Wang and our colleagues think about if you're on a systemic drug, what other things can you combine easily? Let's say radiation, and that's another question. Is like brentuximab is safe to combine radiation with, whereas like certain treatments are not. Especially like total skin, you cannot do it with the like methotrexate and pralatrexate type. So those are always in our mind. There was actually a question in, not today, but sent in question about getting like cataract surgery while you're on some of the systemic treatments like retinoids. There's no great evidence. What do you usually advise, Dr. Wang, about like getting a cataract surgery while you're taking retinoids?
Yeah, I think it's really important to let your surgeon know whether that's dental surgery, eye surgery, or like hip replacement, joint replacement, that you're on these medications to be safe, because retinoids can affect your healing from wounds and surgeries. And for example, I kind of do the same thing with methotrexate, which can also lower your immune system. So higher chances of infections and wound healing delays. I actually have my patients hold it for a certain time before the procedure and then restart it once they're a few weeks afterwards as well. And I don't see a lot of that, short period of a break. I don't see a lot of bad things that happen or any bad consequences from that.
Question about if you have autoimmune disease and MF, how do you consider the link between the two, and having autoimmune disease? Do you have a concern of worsening MF, even if the MF is mild? Your thoughts?
Yeah, I think this is where I think Dr. Jennifer Wang will probably talk more about autoimmunity and B cell lymphomas. But for our T cell lymphomas, a lot of things can happen. A lot of our patients can get other cancers, other, diseases, other skin conditions. We don't see too much of a link with autoimmune, but we definitely, if someone is coming in with Crohn's disease or like thyroid disease, we definitely take that into account. Remember, like for example, like bexarotene, right? That affects the thyroid. So really important. We're trying not to, cause other side effects that will affect their other conditions as well.
Great. And there were some questions about life quality and emotional support. I'm sure we in the Stanford group, we definitely look at the holistic approach. The emotional support is so key because not like any other cancer, this is like a visual, it's a tactile visual condition that affects the life quality mentally and physically more than most other cancers, right? Even in the early stage. So we care about that. And Dr. Wang, what do you recommend as some additional emotional support channels in terms of your collaborative approach?
Yeah, at Stanford, we're really lucky to have a special department called psycho-oncology, and there are psychiatry and psychology group, social workers, therapists, psychiatrists who work specifically in helping to support cancer patients in their journey, because it can be very emotionally, mentally, physically taxing. And so I think we definitely talk about maybe referrals to there. We definitely link our patients to social workers if they need to, sometimes case managers if, it can be very financially or difficult to kind of navigate the healthcare system. So all of those things. And of course, we always encourage patients to bring their family members, right? Caregivers, support systems, because those visits can be long and kind of overwhelming sometimes. And so it's nice to have someone else listening to, taking notes, and just helping to kind of hear everything.
Thank you. And there's one, I think we're going to have one final question because then we'll move on. But anything you can think about diet or your general health way to strengthen immune system to, prevent disease progression, or if you think that is helpful.
Yeah, this is a really common question I get, and my answer is I think there's a lot of I think general practices that I honestly apply to all of us, right? Sleeping well, eating a well-balanced nutrition diet is very important for all patients, everyone, including, but especially important for anyone who has cancer or lymphoma. I think studies have shown that restrictive diets aren't necessarily better, right? So cutting out gluten or sugar extremely does not necessarily lead to better outcomes for people. So I'm not a fan of restrictive or, diets or anything, but I think everything in moderation, everything in balance, but also combining that with good nutrition, good sleep, lowering stress, whatever that means, exercising or meditation, all good things.
Thank you. That was like the perfect last answer to the session. Thank you so much, Erica. It was like great chatting with you also.
Thanks.
We will, and yeah, thank you so much for staying on the next session. I'm going to share the slide. Thank you. Hopefully you can see the slides. All right. Dr. Wang, Jennifer Wang, are you ready?
I am ready.
move
Thank you,
forward?
Youn.
Yeah, thank you. And we have our star, Dr. Wang is, well, she's actually a pathologist and a clinical expert. So that's why she's a perfect person to address a lot of the B-cell questions, because that's heavily based on pathology to diagnose, more than probably the T-cell entities, but she will also address the LYP, ALCL spectrum of disorders. So go ahead.
Thank you,
Dr.
Youn,
Wang.
and thank you everyone for your attention. It's such an honor to be able to interact with the group here and help give you a little bit more information about these conditions. So before we jump into the B-cell conditions, we'll continue with a couple of these T-cell conditions, since we were just talking about T-cell lymphoma, mycosis fungoides, and Sézary syndrome. We can go ahead and move to the next slide. So we'll start off by talking about T-cell lymphoproliferative disorders. And this question comes up a lot. I think it's a very confusing and scary term when you see it on a report. Lymphoproliferative disorder, what exactly is that? What does that mean? And it's actually not a single type of condition. We actually consider this to be a spectrum of different diseases that we lump together because of certain markers that these cells may share under the microscope, and also their clinical behavior. couple main ones or very common ones we see: CD4 positive small medium T cell lymphoproliferative disorder, and then the CD30 positive group of lymphoproliferative disorders, of which two primary types are lymphomatoid papulosis, also known as LYP, or the primary cutaneous ALCL. And one thing to note about all of them is that they are all characterized by very favorable prognosis. So instead of calling them outright lymphoma, which has a very can bring up all sorts of feelings and connotations about being cancerous, these conditions tend to act very benignly and very favorably. So hence the different designation. Just to go over briefly about each of these conditions, it's a lot to talk about in a short period of time, but CD4 positive small medium T cell lymphoproliferative disorder, quite a mouthful for this entity. It used to be considered a lymphoma, but again, because of the very favorable and benign way this entity typically behaves, it's been reclassified as a lymphoproliferative disorder to sort of capture that more benign clinical course. Typically speaking, these things show up on the upper body or the head and neck. Here are two examples. Usually it's a solitary bump. You can be small, it can be fairly flat, it can be a little bit more raised. And many times people will go in and get these biopsied because it's, looks like a skin cancer, it looked like a bug bite that's not going away. And they may be surprised to see that it's actually this entity under the microscope. As I've mentioned, prognosis is very excellent with these spots, and because of the very benign way this entity behaves, we want to make sure that our treatments are appropriately not too aggressive, so that the treatment doesn't become more toxic than the condition itself. Many people choose just to observe these, interestingly enough. People often come in and say, this spot looked, much bigger when I had the biopsy done 2-3 months ago, and they come to our clinic and the spot is barely visible. So it has been reported, and I've seen it myself, that these spots can just self-resolve after biopsy. For more persistent lesions, something very conservative like a topical steroid if it's itchy, or injectable steroids right into the lesion can help them melt away a little bit faster. And in cases that are very, very persistent, or if you have it on the middle of your face and you want it to be gone more quickly, you can do other treatments like low-dose spot radiation just to the area, or even have it excised or cut out. Although, with other potential risks and morbidities associated with those more invasive procedures, such as a surgical scar afterward. But in general, this thing can go away after a couple of months or within a few years, and typically no long-term consequences sequelae from it. So that's CD4 small medium T cell LPD in a nutshell. Moving on to the other group of lymphoproliferative disorders are the CD30 positive T cell LPDs. And as I mentioned in the first slide, these actually represent a spectrum of diseases, with two main entities defining the two ends of the spectrum. One being lymphomatoid papulosis, or LYP for short, and the other being primary cutaneous anaplastic large cell lymphoma. All of these conditions share in common a cell marker called CD30, which pathologists can check for on your biopsy specimens. But the actual name of the condition, whether we call it more lymphomatoid papulosis or primary cutaneous ALCL or something in between, all depends on the clinical presentation. As you can see here, the presentation can be very variable, sometimes lots of little tiny spots, sometimes one very large spot. And just by looking at the pathology report, we cannot tell which specific version you have. We have to be the detectives and put the pieces together, the pathology report, the history of the rash, what it looks like, before we determine the actual name of what you might have. So oftentimes you may come in with just a report that says CD30 positive T cell lymphoproliferative disorder, and it's given a more specific name once you actually are evaluated by the physician. So a little bit confusing of an entity, but we'll go into a couple of these more specific entities. And again, know that this is a spectrum, so there may be some cases that don't neatly fit into either category, but that's why this is such an interesting and challenging portion of what we do. So Going specifically into lymphomatoid papulosis, also called LYP for short, this is a condition that very classically presents as crops of bumps on the skin or papules. They typically crust over, they form a scab, and after a couple weeks or months of waiting, they oftentimes just self-resolve on their own. People can come in with very diffuse spots, like the photo on the left, where it's just bumps all over the body. Sometimes you can just have a localized variant where it's just a few, clustered on one area of the body, like on the other photo there, where it's just a big cluster of them on this person's thigh. Or more regional involvement, where, for example, the spots are only on someone's arm or only on their back, but very variable in the presentation. Many times they can take weeks, sometimes even months, to eventually go away on their own. Depending on how extensive the lesions were, they can leave scars that maybe are a little bit indented, just like you might have after having had a chickenpox virus as a kid. But the general course is that eventually they do go away on their own. Time course, however, is variable. You may have heard or seen in reading about this condition, if you've been diagnosed, that there are different types of LYP, which we refer to as type A, type B, etc., all the way through. I think we're up to type J now. But this sort of alphabet soup of LYP types really just refers to the different ways that LYP can appear under the microscope. So more of a note to us as the clinicians and pathologists to know that under the microscope, this condition can look like many things. So to keep it in mind when you're trying to decide what this condition is. However, regardless of what the type is, type A, type B, type D, it's still considered a condition with excellent prognosis. I don't think the type necessarily correlates to someone who's going to have more refractory disease or not. So in practical terms, the type of LIP you have doesn't really change how we approach your treatment and management. One thing I will point out is that LYP, even though itself is a very benign behaving condition with excellent long-term prognosis and outcomes, there are reports of a small proportion of LYP patients developing eventually a secondary type of lymphoma or other hematolymphoid disease, including mycosis fungoides, which we've reviewed earlier. Sometimes this can also be like a Hodgkin's lymphoma or another systemic lymphoma. So this sort of makes the case for someone with LYP to be continued to be monitored either by their dermatologist or just in general by their regular primary care provider to make sure that there's no abnormal findings in their blood or in their general health that might alert them to possible development of a secondary lymphoma. But again, this isn't super common, but something that you should at least be aware of, and your providers hopefully will be aware of as well. So in terms of treatment for lymphomatoid papulosis, a couple different options. And again, because this generally is a very benign behaving condition with really no negative long-term impact on your overall health and your overall longevity and survival, we again want to make sure that we're matching the severity of the treatment to the severity of the disease. Because LYP oftentimes does just resolve on its own, and the recurrences are variable, some people just choose to observe the spots and just wait for them to kind of go away after a couple weeks. It is something that does tend to recur, and the frequency of the recurrence is very, very variable between patients. Some people get new spots once a month. Some people, it's years between their individual spots, so a little bit hard to predict the frequency. And so if someone really isn't bothered by it, just got a few spots, they went away, maybe a year later got another few spots, they may choose just to observe them and let it run its natural course. Sometimes they can be a little bit itchy, or if you want to try to get them to resolve faster, you can attempt treatment with topical steroids, or for something that's a little bit thicker or juicier of a bump, you can try to inject it with steroids to maybe help it shrink faster. And for people with many, many spots kind of covering their body, just like with mycosis fungoides, that might be more diffuse and where it might be impractical to put topical steroids, or again, you just want to get better control over the disease if it keeps coming back every single month. Narrowband Light therapy, phototherapy can also be used, and it's also very safe and effective. But as Dr. Wang described during the Q&A session, it is sort of a time commitment and can take a while to show results. But certainly a very safe and effective option for this, and a treatment option that can be reused and reintroduced in the future if you took a break from it in the past. We tend to reserve systemic treatments for much more recurrent, refractory versions of the disease, again, because of the potential toxicities associated with these systemic treatments. Methotrexate is an oral medication or injectable that can be used to control very frequent, very symptomatic, bothersome cases of LYP, but again, does come with some risks and laboratory monitoring. Similarly, brentuximab is an infusion for very, very refractory disease, again, with much more risk and potential for long-term side effects, including neuropathy, as we discussed earlier. So typically not our first-line options, but certainly something that can be considered if someone just hasn't had much success with the other options that we've reviewed. So that is lymphomatoid papulosis in a nutshell. On the other end of the spectrum of the CD30 positive lymphoproliferative disorders is our anaplastic large cell lymphoma, primary cutaneous version of that. And this usually presents as like a single solitary bump on the skin. Oftentimes it ulcerates and the skin surface kind of opens up, much more aggressive and scary looking than the LYP spots that you get. Interestingly, sometimes these can also resolve on their own, but usually they are a bit more recurrent and a bit more stubborn. If we can move on to the next slide, we'll see that with this condition, there is a systemic version of ALCL. So whenever we see someone with this in the skin, we also want to make sure it's not actually systemic or internal nodal ALCL that's now presenting itself externally on the skin. So usually we have people do some sort of imaging, a PET CT or chest, abdomen, pelvis CT to make sure this isn't systemic ALCL we're dealing with. That would require a different path of treatment. If we confirm that it truly is just skin-only disease, generally it does not spread to other parts of the body. Rarely it can, so it does require close monitoring, but that I would say is much more the exception than the rule. And even though it looks much more aggressive and gnarly than LYP, its prognosis is still very favorable, particularly compared to the systemic version of ALCL. So for this particular condition, treatment-wise, because it is usually a single lesion, we can do much more localized treatments like excision, surgically just cutting out that lesion. Radiation also quite effective for this as a single spot. But again, if there are more diffuse lesions or it's very refractory to treatments, or if there's any evidence of internal systemic disease, that's when we then start reaching for systemic therapies. So that's our CD30 lymphoproliferative diseases, and certainly happy to take questions about that. Again, lots of variation in how those present, but we'll now move on to our B-cell lymphomas to change gears a little bit. And with our cutaneous B-cell lymphomas, the way I like to think about it, there's two main classes of these. And again, the B cells are the other immune cells other than the T cells, but still very important part of our immune system. We have either indolent behaving B-cell lymphomas in the skin or the more intermediate aggressive behaving ones. In our indolent family, these are certainly the more common variants of cutaneous B-cell lymphomas. We have our primary cutaneous marginal zone lymphoma and primary cutaneous follicle central lymphoma. And then in the more intermediate or aggressive behaving class, there is primary cutaneous diffuse large B-cell lymphoma leg type, which we'll touch on briefly. Just as I talked about getting imaging done for cases of primary cutaneous ALCL with cutaneous B-cell lymphomas, we also want to make sure this isn't a systemic or internal B-cell lymphoma that's presenting with bumps in the skin. It's not very common that people with skin involvement, skin B-cell lymphoma, cutaneous B-cell lymphoma actually have systemic disease. We and a group over at Memorial Sloan Kettering looked back at patients with B-cell lymphomas and found that there are, some people in marginal zone lymphoma, about 3.6%, and with follicle central lymphoma, about 8 to 9% of cases who present with only skin disease who on imaging actually ended up having systemic disease. And I certainly have had patients coming in and for cutaneous B-cell lymphoma, where upon doing a PET scan, we actually identify that they have systemic disease. And that, of course, then, we'd want to manage differently, probably have them link up with an oncologist for a systemic treatment. And so typically an imaging study of some sort, whether it's a PET scan or a CT, chest, abdomen, pelvis, is performed at time of diagnosis to make sure that we truly are dealing with skin-only primary cutaneous disease. Going into the different versions, primary cutaneous marginal zone lymphoma, some example photos you see on the right there, generally affects the trunk, the upper arms, and upper legs, so sort of the center of the body. Usually they're very thin pink bumps, sometimes a little bit more raised. They can be single spots, or they can be more generalized, multiple spots, like that image of the shoulder there. Sometimes they're asymptomatic and people really aren't bothered by them other than the fact that they're there. But for some people, they can be quite itchy, and that's maybe what's prompting them to seek treatment. Primary cutaneous follicle central lymphoma is fairly similar. Usually this is more sort of upper body, head and neck predominant, very common on the face, the scalp. And these, in my experience, usually look a little bit thicker, a little bit more pink purple in color, not quite as flat as the marginal zone lymphoma cases. And just like with the marginal zone ones, they can also be very itchy, and that often does drive people to try to seek treatment for these. Speaking of treatment options, many things that we can pick from. Radiation is oftentimes our first go-to because we have a great collaboration with our radiation oncologists who have a lot of experience in treating these lesions. The radiation typically is fairly low dose so that they can use much higher doses if it's just a single lesion or one that's very aggressive looking. Generally speaking, it does typically clear with radiation, but with radiation, or actually with all of our treatments, it is expected that the lymphoma may recur again in the future. This is something that we can't fully cure in terms of get rid of once and for all, like you can get rid of an infection with antibiotics, but we can manage spots as they come up. So just because one treatment didn't work and you get a new spot later on in life doesn't mean that it's becoming more aggressive. It's just sort of the natural expected course of the disease. Steroid injections or steroid creams can be helpful. Cutting it out surgically, sometimes people opt to do that, but again, with risk of having a large scar there. And some people I've also had just opt for observation. If it's a single non-symptomatic area, they're not too bothered by it. Again, because these lymphomas have a very good prognosis in general and don't usually make people very sick or have long-term consequences, some people choose to do nothing. And sometimes I have seen this sort of melt away gradually with time. Systemic treatment can be considered. Rituximab infusions, which is sort of an anti-B cell treatment. We do reach for that every once in a while if someone has very generalized refractory disease. But again, being a systemic treatment does come with a lot more risks and side effects, including immune suppression. So it needs the appropriate person and obviously a discussion of risks and benefits. Finally, just a brief word on primary cutaneous diffuse large B-cell lymphoma, leg type. This is much less common than marginal zone and follicle center. This one's associated with more intermediate prognosis, a more aggressive treatment, or more aggressive disease, we often do want to have it more aggressively treated. Usually in older individuals, there's a female predominance reported, but certainly can happen to younger individuals. It's called leg type because usually it's on the leg and that's where it was first described, but it can be on other parts of the body. I have an example of someone with more forehead, facial, and head involvement. So just because it's not on your leg doesn't mean it's not that condition. And sometimes it's solitary, sometimes it's multiple tumor nodules. But most importantly, this is something that we have to collaborate with our medical oncology colleagues because the treatment is typically combination chemotherapy. So I think that wraps up the overview of the B-cell lymphomas. Happy to take any questions about these two topics.
Yeah, I'm going to try to direct the questions. Maybe we can go back to the unresolved one on the prior session was to how do you, and this, I have to tell you, I'm going to first of all fire myself as a slide advancer. I've been doing a lousy job, but keep me employed. But wanted to ask you, how do you distinguish between MF and CD30 LPD entities like LYP, MF that are papular, or in the tumor lesions like ALCL or MF with large cell transformation? How do you distinguish that, Dr. Wang?
Yeah, it can be very tricky. I will just start by saying that. Under the microscope, it can be very challenging too, because multiple conditions, even though they look different on the skin, they can sort of share the same markers. And so the pathologists only have, very limited view of what's going on in the patient's overall picture. So just because something expresses CD30 doesn't necessarily mean it's a CD30 LPD. In terms of LYP versus mycosis fungoides, again, sort of that clinical history of, are these spots, do they come and go? Do they come in crops? That's a little bit more fitting with an LYP picture. MF, usually more like a rashy flat patch, can present as more small bumps, but in my experience, at least, the MF bumps tend to be a little bit more persistent. They don't have that coming and going behavior that the LYP lesions have. Sometimes it's tricky because LYP and MF can coexist, and I have many patients who have a little bit of both. And there's versions of LYP that can mimic MF under the microscope. That type B LYP can look just like MF under the microscope. But again, you have to kind of bring it back to what's actually happening on your skin. So very challenging. And I think similarly with the ALCL picture and tumors of MF, usually ALCL has different markers that it might present. Again, the CD30 tends to be a good clue. If that's very, very strong, that might be more fitting for an ALCL compared to an MF. But there's more aggressive versions of MF, like the large cell transformation, that can also express a lot of CD30. But again, that clinical behavior, MF tumors tend to be more aggressive behaving, longer lasting. They don't really regress. ALCL, the primary cutaneous ALCL, maybe not quite as aggressive, rapidly progressing, might be more singular in nature. So hard to give a general answer because it kind of depends on what's happening in the patient's skin, but it can be very, very difficult.
And the MF patients would definitely have other patches and plaques usually
This
when
is
they
true.
have the tumor. I'm assuming you would use that. Some great questions on brentuximab or like systemic treatment in ALCL. So there are questions about at what point would you consider more than local radiation? So if you had localized single or group ALCL lesions, you would radiate. But at what point would you employ systemic therapies such as brentuximab or other?
Yeah, I think again, sort of depending on the particular situation and the risks of the treatment and whether it's worth the treatment. If it's a single area and it's failed, some of the more localized treatments, that would be certainly a reason to consider moving on to something like brentuximab. I think certainly more widespread or diffuse lesions may be easier to address with a more systemic treatment. But again, if it truly is primary cutaneous ALCL, we have to make sure that we're weighing the risks of neuropathy, infusion reactions with brentuximab. It can be combined with some of these other modalities, as you mentioned, Youn. So you could radiate some spots and maybe do brentuximab to treat the other areas. But again, kind of dependent on the bigger picture of what's going on, other disease comorbidities included. So.
Great, thank you. And then the question about if you had, you mentioned about other malignancies developing in patients with LYP. Question about if you're a younger person, because there's longer time to develop other cancers, is there more of a concern or not with time?
Yeah, I don't know if we have data to suggest that there's like a cumulative risk over time. But I think it still is, a good reason to continue with your general healthcare maintenance. Obviously, being aware of it can make you a little bit more attuned to like, oh, if you develop a weird rash in the future, maybe that's MF that's popped up alongside your LYP. So certainly to just know about these things so that you can bring them to the appropriate provider's attention and get diagnosed with, concurrent MF. Seeing your primary care just for lab tests, because if suddenly your blood counts start increasing for unclear reasons, If you're having fevers or weight loss or some of these more concerning systemic symptoms, they can be on top of, addressing and diagnosing it early. But I don't think there's necessarily been a cumulative risk over time that we've demonstrated for concurrent lymphomas and LYP.
Okay, great. Think that is there in your B-cell lymphoma, is there a process that you use in terms of how to pick the different treatments on the indolent disease, like whether you inject steroids or decide to give low-dose radiation, or how do you decide with the patient?
Yeah, I think it's more of an art to a science, I think, because there's many different ways we can treat these. I will oftentimes pull in our radiation oncologist to get their opinion because some areas of the body may be a little bit more complicated to treat than others, especially when we're dealing with like follicular lymphoma on the head and neck where there's curved surfaces, or if there's multiple spots they'd have to address. It may be a little bit more challenging to get to it with radiation compared to just injecting it with steroids. Some logistical things I think also play into the patient's decisions. Radiation often is administered over several sessions. There's a planning session. The radiation dose may be given over a couple of days, maybe a few weeks, depending on the dose they're using. And some people just don't have the resources or the time to go in for so many sessions. So they may opt for treatment with steroid injection, which is an in-office procedure that can be done in a few minutes. Some people do both. Some people are scared of needles and don't want to do injections, they just want to go for radiation. So sort of a conversation with all the involved parties about what makes sense for that particular person.
Thank you. I think I just want to make sure that the audience is aware that each of our experts, they obviously treat all of the types of cutaneous lymphoma, but obviously they were trying to divide our roles and trying to on this session. So I want you to know that our physicians are able to see any of your spectrum of presentations, advanced or early. And I'm wondering if we could take a 5-minute bio break now.
Everyone, welcome back. We have Dr. Kim presenting, and we will take another Q&A after, so please continue to enter your questions into the chat. And just a reminder to do keep those questions general in nature and not specific to cases. Thank you so much.
Okay, thank you. Gonna move it along. Obviously, while I'm talking, I wouldn't be able to pay attention to the questions. So I'm sure Laura will track them, and I'll get back to them, get back to your questions after Michael finishes. So I'm gonna start with a clinical trials introduction, and then Michael is gonna go into all newer therapies, all the innovations, and then we will have a good amount of question answer session at the end. Thank you. And I see a lot of friends and colleagues who joined the event, and I'm very grateful. And we're very excited that, again, we're holding this session. So what's next in the cutaneous lymphoma, T-cell lymphoma landscape? As you heard, highly heterogeneous group of disorders. And thus, not only do we need to develop new therapies and improve patients' quality of life outcome, we need to learn, again, not one therapy you heard can address all the compartments of disease, skin, lymph node, blood, viscera. You have to often combine them. We have to get ahead of the cancer, so we have to combine and then prevent resistance. So we need to learn how to combine therapies. And then we need to, in the heterogeneous disease, we need to know how to predict and how to match the treatment with the patient's disease profile. And that's called the biomarker guided management. How do we align them better with patients' characteristics? And obviously to do that, we're going to be integrating a lot of multidimensional data. We will utilize a machine learning AI to help integrate all that data to represent the patient. So it may surprise us that something that we think is slower moving may actually be better if they're equipped with the right biomarkers to be aligned with the treatment. What is clinical trials? Well, we need to do clinical trials to get the drugs evaluated in the patient. And there are phases of clinical trials that I will get into, but obviously there are trials in animals, but we're talking about human subjects. So it's clinical studies in human subjects. We would test health-related interventions and outcomes with clinical trials. And a lot of the key questions that we address and answer is the intervention safe? What kind of dose and regimens will be used that are ideal? What are the responses of the treatment? Can it prevent the progression of disease? There were great questions about that. Compared with existing treatments, how can we do better? Does it improve the life quality of the patients? What do we study in clinical trials? Anything from drugs, devices, surgical radiation, diagnostic tools. Good questions about cell-free platforms. Those are all like trying that out would be in a clinical trial context, and quality of life, holistic diet and lifestyle changes as well. And why are they done? Obviously, we need to generate very quality data that are controlled. So even their it's called clinical trials when we use approved drug to study it more intensively, because we want to do it in a systematic way with quality and consistency. And then we can determine more about what's best for our patients. Now, the phases of clinical trial that you hear about, the preclinical part that precedes the human trial is all the laboratory animal studies that could be done that complements the human study package. Phase 1 is the focus on the first in human. We have an exciting drug. We need to see how it works in the patient compared to a mouse. And that first in human safety study is usually phase 1, often dose escalating. So we would escalate from very tiny dose to higher, so we can find the optimal dose that's safe and has potential activity or effectiveness. And phase 2 is that we have some idea of safety. Now we want to learn more about the efficacy, and that could be 2 different doses, 1 dose, it may be selective doses that we will expand and optimize, understanding about that selected dose. And we continue to always collect safety data. Phase 3 is now the next level where we take it to registration, FDA registration organization to get it approved. And that would require larger size. Even in rare diseases, we would have to have larger size. And often it is randomized control trials that the FDA will accept. And it would be either against an existing approved treatment or some physician's choice accepted treatment to compare with the newer drug of interest. And it will be focused on efficacy, though we continue to always collect safety data. Phase 4 is after the drug is approved. We may need to learn about long-term effects. 10 years, like what happens? Is there any autoimmune disease that gets developed? Is there cardiac toxicity with long-term exposure? And some real world representation is often investigated in the phase 4, or selective ethnicity. Is there a special toxicity for a certain ethnic population? Those are all phase 4 after the drug is approved. And usually about 70% of the drug is moved from phase 1 to 2. And of those, only about third is moved from phase 2 to a phase 3 trial. And of the phase 3, only about a quarter to a third is actually approved. So only a very narrow approval rate. And again, why do we want to do all this? Is that we do need to have patients involved and integrated into this whole process. The patients bring very important, vital perspectives to strengthen our clinical trial and research. And in fact, CLF, Cutaneous Lymphoma Foundation, served as a vital organization linked with the FDA to represent the patient's perspective. And always the CLF has a seat at the table for drug approvals, because patients' voice is tremendously important. For example, romidepsin, when that drug was approved, it was vital that a patient's testimonials about the drug, how it helped their life quality and functionality, it was very integral to the approval of the drug. So you can imagine that partnering with the patient all the way to the phase 1 to the pivotal trials, optimizing the trial design, inclusive diversity and equity to represent patient populations, and to hear about their opinions about quality of life that's impacted is all very integrated into approval. So again, meaningful patient involvement leads to research that is more ethical, inclusive, and impactful. So it's vital that we work together with you. So then I'm going to hand it over to Dr. Khodadoust, who's going to talk about the new therapies. And I will try to advance the slides and not get fired accordingly.
I'll let you know if you're
Yeah.
fired midway through.
Okay. You'll give me the signal. I'll look for a job. Now, Dr. Khodadoust is our medical oncologist. He also has a secondary appointment in dermatology because he's so now astute with dermatologic entities. And then he's also our translational basic science lead. So it's very important that we partner together so that like research discoveries make sense in the patient. And if we have problems with understanding patients' response or presentation, we take it to the lab and we bring it back to the clinic. So with that introduction, Dr. Khodadoust.
Thank you, Dr. Kim, and thank you all for joining and for staying on. And you are also an important partnership. As you know, this is a very rare disease, and it's really important to have a community to advocate. You were just hearing from Dr. Kim the challenges with clinical trials and the importance, and so thank you for being part of this meeting. All right, so we're going to talk about some of the new directions, mainly in therapies, and we can go ahead and advance the slide. All right. So therapies and strategies, go ahead, next slide. And I'm going to try to keep it very high level. I'm going to avoid going through a lot of data, and we're going to try to talk about just concepts and really how we're approaching trying to make a difference and really advance treatments. So cutaneous T-cell lymphoma is really challenging compared to many types of cancers because it has really unique aspects. And one of the big ones is that we have to deal with cancer cells in so many what we call compartments. So these are all unified by the fact that they are skin lymphomas. So they're always in the skin, but as you've been hearing about, and as many of you may know, the lymphoma cells can go from the skin into the blood, and we call that leukemic involvement, blood. It looks like a blood cancer. They can go into the lymph nodes. They can go even into organs. And in addition, when they're in the skin, they can behave differently. As you were seeing, different patients have different involvement. Some patients have it involving their whole skin. Some people have tumors or nodules, and some people have ulcerating lesions. So we have to be able to treat all of these different areas, and often our treatments work differently in these different areas. So that's a major challenge. Next slide. So you were hearing Dr. Wang did such a great job. Both Dr. Wangs did such a great job, but discussing the treatments for MF and Sézary and how we try to match them to the patient. Because we have people who have just very limited disease, just a few patches, plaques, and those people we want to treat with mild, safe therapies. We don't want to cause harm. We don't want to cause toxicity with our treatments. And then we have all the way to the spectrum of people who are dying of their lymphoma. Their lymphoma has perhaps gone inside, perhaps going to the lymph nodes, causing major issues. And in those patients, we want to consider every treatment available, including IV therapies, including even sometimes chemotherapies with more risks, more side effects. So it's also unique because we have so many different classes of treatments for CTCL. Many cancers we think of chemotherapy and radiation, and those are the backbones, but you were just hearing about all of these different names, and I know this can be really overwhelming, but one way to think about this and thinking about how we move forward into the future is you can kind of put our therapies into these big buckets. We talked about radiation therapy, and we use light. We use photons in terms of UV photons. We sometimes can use UVA, UVB. You can use electrons. Those are all radiation. They're all very, very effective treatments for cutaneous lymphoma. We use them in different situations. There are therapies called targeted therapies. Targeted therapies are designed to target pathways, to target mechanisms that turn these cancer cells into cancer cells. So you can think of a cancer cell as a cell that is growing too much and not dying enough. Those are two of the main hallmarks of a cancer cell. They should not be persisting. They should go away. Normally, our T cells don't keep dividing. They'll die off. These cells are not doing that. And that's because they turn on switches and pathways that keep them moving forward. And so we can use targeted therapies, knowing the science behind what's driving these lymphomas to grow. We can try to block those signals. So that's targeted therapies. There are chemotherapies. Chemotherapies are typically drugs that damage DNA, that cause damage to the genome, that cancer cells are having a harder time to repair than our normal cells. We kind of damage the DNA in a way that would kill a cancer cell, but a normal cell will stop and fix that damage. We don't use this as much for cutaneous T-cell lymphomas because they tend to be very resistant to most of the traditional chemotherapies. And then there are kind of the I think, most exciting areas of research moving forward, which are immune-based therapies, antibody-based therapies, which I'm going to talk a lot about, and in the future, cell-based therapies. And it can be a little bit confusing because some of our antibodies actually work to activate cells. So we've already talked about brentuximab and mogamulizumab a little bit. I'll talk a little bit about that. And then lacutamab we'll talk about as a promising new therapy. And then cell therapies. Many of you who are looking into the research in the field, especially in lymphomas, may know and be hearing about things like CAR T therapy, chimeric antigen receptor T cells, or bispecific antibody therapies. So we'll talk about that. All right, so the good news. I put this slide together recently for a different talk, and this is a slide showing the approvals of different drugs for lymphoma since 1997, when rituximab, one of the very first drugs, came out. And so you can see that it's accelerating. Somewhere around 2018, you can see this inflection point where we're getting drugs every year and sometimes multiple drugs a year. And it's just a really exciting time. So that's the good news. And you can see also new classes of drugs. It's not chemotherapies, it's all these other therapies. But if we go to the next slide, you see the bad news, which is that of all those drugs, only 6 of them have been approvals for cutaneous T-cell lymphoma. And most of those, vorinostat, pralatrexate, romidepsin, brentuximab, those drugs have been approved many years ago. Mogamulizumab was approved in 2018, and actually Dr. Kim played a very pivotal role in helping with that approval. And then we did get a new approval for a drug last year. It's actually a drug that had been around for a while, but retooled. It's a drug called Lymphir. And even though it's FDA approved, we actually still don't have access to it quite yet. So that is one new positive piece of information. So many of the drugs and many of the exciting therapies that we have for CTCL and these immune therapies, they work by targeting proteins on the surface of the cancer cell. And in lymphoma, we have many great targets that are only on lymphocytes. And we have an analogy. You heard about some B-cell lymphomas and B-cell cancers, and then there's T cells. These are 2 arms of the immune system. And we have this benefit of having these great markers And in B-cell lymphoma, the strategy has been take anything that's on a B cell and target it, kill all the B cells. And it turns out, surprisingly, you can kill all of your B cells. We call that B cell aplasia. You can get rid of all of your B cells and you will live and you'll do well. You may need some extra treatments. You may get more infections, but we can support you through that. The problem is with T cells, and including cutaneous T-cell lymphoma, if you kill all your T cells, you will not survive. You will inevitably die of infections. We cannot replace our T cells. We need them. So our targets tend not to be targets that kill all T cells as much as targets that are only on lymphoma cells. And the big ones that have been more advanced in treatments are CCR4, we'll talk about. That's the target of mogamulizumab. CD30, that's the target of brentuximab. And then two new ones, KIR3DL2 and CD70, we'll talk about as targets. All right, so antibody-based therapies. I mentioned that rituximab was a drug that was approved back in the 1990s. It was actually an antibody developed largely at Stanford by Dr. Ron Levy, who is still around and doing great work here. So this is a way to use a part of your immune system that usually fights bacteria, fights viruses. It's designed to go after bacteria and viruses and bind them and help flag them for your immune system to kill them. Well, there was a paradigm shift when people realized that you could actually make these antibodies not attack just bacteria and attack viruses, but you can attack anything you want, including things on the surface of cancer cells. So we now generate these antibodies to target molecules that flag the cancer cells. So CCR4 is a molecule on many CTCL cells. Most CTCL have CCR4, and there's an antibody named mogamulizumab that will bind to that, flag it for the immune system to kill. Brentuximab, very similar, it binds to something called CD30 on lymphoma cells, and that's a little bit more variable. And there's one big difference with brentuximab. It's actually part of a next generation, not just an antibody. We found that if we just used the antibody against CD30, it wasn't quite potent enough. It wasn't really working as well as we would want it to be. And so they generated a conjugate where the antibody was actually bound to chemotherapy. And that way, the antibody took the chemotherapy right to the cancer cell, and it gets internalized into the cancer cell. The chemotherapy gets released, kills the cancer cell, and also has some benefits because then that chemotherapy can actually kill some of the surrounding cancer cells as well. And that is a very, very active strategy across cancer, and especially lymphoma. The idea of not just using an antibody, but actually attaching drugs and chemotherapies to the antibody. Next slide. So actually, Dr. Wang covered this really well. So there are some differences. Mogamulizumab and brentuximab have really been paradigm changing in giving us two amazing new therapies to treat CTCL. And they're very complementary. Moga is very good in the blood. It can wipe out leukemic cells, those circulating lymphoma cells in the blood, really well. Brentuximab has a different specialty. It can work on some of the nastier large cells, and it can work in lymph nodes better than mogamulizumab. So we kind of use these in those different settings. They also have both downsides. Mogamulizumab, I mentioned, does not work as well for those large cells, also often associated with a rash. Brentuximab, that chemotherapy can kind of leak out and actually causes damage to nerves. And so over time, if we keep giving brentuximab, we have to watch for that nerve damage. And so there's actually efforts to change the way that we've made brentuximab to not cause the nerve damage. And that's kind of the next generation that we're looking at. Slide. All right. And one of the most promising drugs and one of the most exciting ones that we've been hearing about in recent meetings is this drug. It's got a very French name, lacutamab. It's from a French company named Innate. And this drug targets a molecule called KIR3DL2. You don't need to know about that target. except that it is often expressed on Sézary cells and other types of T-cell lymphomas. And there has been a phase 2 trial completed for patients that have already had mogamulizumab. So people that have already had that moga and they can't get it because of rash, because it stopped working, this is where lacutamab may have a role. And next slide. And this is a patient actually treated here at Stanford by Dr. Kim on the trial. This is a patient who had 5,000, actually 500,000 Sézary cells per microliter in their blood, high level of Sézary cells in the blood, a lot of skin involvement, and actually lymph node disease. And on the trial, had a complete remission, meaning in all of those compartments, the lymphoma was wiped out. And not only did they have a complete remission, it lasted well over a year. And so when it works, it really works. All right. Another strategy, different than the antibodies that target the cancer cells. So we've been talking about antibodies that go to proteins on the surface of cancer cells. There's another big paradigm shift that happened in cancer treatment where we can use antibodies that don't target cancer cells, but actually target your normal cells in the immune system to make them work better. And what's amazing about cancer, including CTCL, is your immune system is trying to help fight cancer all the time, many types of cancer. And that includes these cutaneous T-cell lymphomas. And for many people, it's probably working to protect us from these lymphomas. It's probably part of the reason why these aren't as prevalent as they could be. But lymphomas are tricky, and the CTCL cells are tricky, and they've actually learned how to put a switch on their surface that will shut off the immune response. And so this is, we call this switch PD-1 and PD-L1, and this is a way for the lymphoma cells to say, don't attack me, I'm good. But there's an antibody that can block that switch. And so if we block the switch, it turns the T cells back on, the good T cells, and they can kill the lymphoma cells. Next slide. And the good news is that this can work in CTCL. It's actually one of the few lymphoma types where these PD-1 blockers is effective. The bad news is it only works for about a third of patients, and you have to be ready because often it will get worse before it gets better. There's some complex interplay there where actually the lymphoma can spike. So if you need a benefit right now, tomorrow, this is not the drug for you. All right, so I'm already running a little bit over, but I'll pick it up a little bit. So these PD-1 blockers, they do work in about a third of patients, and a lot of the trials going on right now are trying to figure out a way to move that to a higher percentage of patients. And so an exciting trial that came out from our colleagues at City of Hope, looking at a different PD-L1 blocker plus another drug, found that over half of their patients responded, and these are photos from their trial. So the hope is that we can better use this whole class by combining. Next slide. But the future may be cellular therapies and some of these other therapies. So CAR T therapy, many of you have probably heard about this. CAR Ts are cells that are genetically modified. You can actually go into the DNA of cells. We have different ways to do that, and we can cut the DNA and add a gene that we want into the DNA. And in this case, we can add something on a normal T cell that will make it attack whatever we want. So next slide. And there's a reason that this is a little bit more challenging, again, for T-cell lymphomas. And the problem is the cell that you put these genes into are T cells. Usually you're putting these cells into T cells to kill a cancer, a B cell cancer, or they're working on breast cells and pancreatic cancers and those things. The problem is if you train a T cell to kill T-cell lymphoma, they often will kill each other because these markers are on these cells. So we have a term for that. It's called fratricide. Instead of killing the bad guys, they're going after each other. And so that's been one of the major challenges. Next slide. But it turns out there are really smart people who have some really clever ways to get about this, and many of you may have heard of this technology called CRISPR. It won the Nobel Prize a few years ago. It is a way where we can cut DNA where we like. We can actually direct those cuts. And this is an example of this drug called CTX130. This clinical trial was reported out a couple of years ago. They can actually cut the DNA and cut out genes we don't want and put in the gene we do want to help reduce fratricide, to help reduce other issues and complications. And I think it's becoming clearer and clearer that these strategies that people talked about actually will work if we put them into play. All right, and then another whole class of drug that has been really revolutionizing cancer treatment are these things called bispecific antibodies. The antibodies I talked about before, they target one thing. So they target CCR4 and they have two arms. They grab CCR4 and they grab CCR4. Well, we've been able to engineer ones that can grab CCR4 and can grab something else. We call that bispecific. And the way we're using this is we use one arm to grab the cancer cell that we want to get rid of, and we use the other arm to grab a good T cell. And when it grabs that good T cell, it doesn't just grab it, it actually activates it. It can turn it on at the same time. And so it pulls the two cells together and it tells the T cell, the good T cell, to kill the bad T cell. And this is a really interesting strategy. Again, there are complications because it's T cells versus T cells, but we're beginning to see the first trials of this going on and starting to see whether this will work. So this is part of the future. And one of the big goals in CTCL, and you were hearing about biomarker-driven treatment, is we know right now, we say things like this drug might work for a third of patients, but we don't know who those third are. So if we knew who it was, if we knew that you were in the 30% where this drug is going to be a blockbuster, that would be a huge advancement, even without any new drugs. So we're trying to go from this generic, let's give one drug to everybody. If that doesn't work, then we give the next drug. We're trying to choose better, to understand what makes these drugs work for different people. We call that personalized therapy. This is an example of a patient that we treated here at Stanford with a very particular rearrangement in their DNA. And based on this rearrangement, we thought that this drug, which is an inhibitor we don't use very often, actually very rarely do we use this for CTCL treatment, but we thought that this would be a good next treatment for her. And she had been through many lines of treatment. And you can see that this pill called ruxolitinib, mild therapy, really worked very well for her because it was a good match. But we're also learning from the research that we're doing in the lab and around the world that there are major challenges to this, and a big challenge with CTCL. And for those of you who have been going through this process, you've been seeing this happening in real life. What we realize is that CTCL, even though every patient is different, actually in the body, in these skin lesions, there are differences. And we call this clonal evolution. They all came from one bad cancer cell, but over time they change. And when we sample and choose a drug, we may choose a drug, this purple drug that might work for these purple cancer cells. And we think, this is a good match. Look at these purple cancer cells. We see a weakness. Let's attack it. We give that drug, and maybe the lesions get better. But what we're doing is we're uncovering the other clones that were resistant.
Sorry, Michael. There's some, let me go through some of it. I don't know, here.
Okay. Yeah.
I am fired.
No, you're doing great. I'm fired because I think I'm going over. But this was to go into the next part of it in terms of tracking. So this was a question that came up too. How do we track? And you heard Dr. Erica Wang talk about using TCR MRD. Those of you at Stanford, we have our own test. Many other places, they use an assay called clonoSEQ, you may have heard of. This is that bar-coded way of tracking DNA in the blood. We can track the cancer DNA once we know what we're looking for. But we are doing research, and others are doing research looking at other ways to track this, not just through that one receptor. Oh, good. So we have some time. Not through just that one receptor, but using other receptors. and also not just looking at the DNA in cells in the blood, but actually looking at the DNA that has leaked out of the cells. So work here at Stanford and other places have found that it's sometimes better to track cancer DNA not in the cancer cells they get around, but rather because cancer cells are constantly turning over, they shed their DNA into the plasma, into the liquid part of the blood. And if we get the liquid part of the blood, we actually have a better way to track the cancer cells. And this is work by one of our postdoctoral fellows at Stanford, Nicholas Bastidas-Torres, who compared looking at the DNA in cells versus the DNA that had leaked out of cells. And in 18 patients, he was able to find cancer DNA in the cells circulating in the body. But if you looked in the plasma, he was able to find it in 75%, 14 patients. So we do think that this could be the future to look at cell-free DNA. But the caveat, and also bringing it back to the question of one of the participants, to do this in CTCL, we can't use off-the-shelf panels very easily. So a lot of these tests that are designed for all of breast cancer patients or all of leukemia patients don't work for CTCL because everybody's cancer is so different. We really have to use a personalized, actually, detection panel to make that effective. So the future is really personalized treatments, personalized detection, because the cancer is so different for everybody. And we really have to focus not on something that will work for everybody, but we got to embrace these differences and make sure that we're treating everybody's cancer the unique way that it needs to be treated. All right.
Okay, we're
very
gonna,
much.
Dr. Khodadoust, thank you, Michael, so much for that. And I'm gonna actually, before we open up for general questions further, catch up with some questions. There was questions on photopheresis, and I think we haven't really covered that immune therapy. Maybe you can talk to us about phototherapy and when you would consider that, early stage, advanced stage leukemic, your thoughts.
Sure. And for questions like this, obviously, Dr. Kim, but Dr.
Wang's,
and Dr. Wang,
Jan
both of
and
you guys,
Erica, please
please
chime
do
in.
feel free to chime in for all these. Photopheresis is a really interesting, I put those little buckets there, and photopheresis is not in any of those buckets. It's another one of those unique things, pretty much only used in CTCL. And it's not super well understood how it works. Well, I shouldn't say that. Some people really think they know, and we think of it as maybe an immune therapy. And so it's one of those interesting things that may be helping to train the immune system. And because of that, it is really good for combinations. And I think the question is, do you use it as a monotherapy or combination? And I think it's one of those that is ripe for using in combinations. And feel free to say how you guys like to use it.
Yeah, I think there's actually some data that obviously it's an immune, we think it's an immune therapy, utilizing tumor antigen and processing macrophages, going back as an immunization process. So it would make sense that if there's some disease in the blood, even if it's a low amount, so they can immunize against when you turn on the light and creates that immune activation. And so anything that helps augment that immune activation, and that, so traditionally it's been combined with interferons at lower doses, not higher doses, or low dose, well tolerated. And that's the common one to combine. Now, I want to just segue into a question about the lympher that you mentioned about the CD25. Now that we have another target, it is approved, but it's not available in the market yet, but we hear that it's going to be soon available. Do you want to comment about lympher?
Yeah.
The drug toxin, antibody drug toxin. Yeah.
Yet another unique drug for T cells. So that is a kind of completely different way of treating, where you can actually attach a payload, in this case, diphtheria toxin, to a molecule that would usually go to a T cell. And so the very first version of this has been around a long time. We used to call it ONTAC and denileukin diphtox. And the problem was they had to come up with a new way to refine the product. So it had to go through FDA approval again. It is one of those that would be great to have access to because we've had patients that have burned through all of the other therapies and yet have had a great response to that drug. So we're all waiting for that to become actually physically available to be able to give to our patients. But we hear 2026 is the latest estimate.
Yeah, around the corner. And it would be another important immune therapy for our patients. I think this question is very interesting from Bruce about T-cell drugs that are approved in other places and if it's available in the US, including like EZH2. Can you comment about some T-cell drugs outside?
And again, everybody feel free to chime in, but it's usually, I would say it's usually the opposite that I would say the US tends to have access to more of these drugs than other places. There are some rare instances where other drugs are available elsewhere. EZH2 is a target that is in clinical trials here. It's available as an approved therapy in China, for example, for peripheral T-cell lymphoma. But for the most part, I think most of the therapies we tend to get earlier access to. Moga and Youn, you can share. You work a lot with our European colleagues, and as we think about therapies and trials, we often have to think about what's available through the European medical, and our Canadian colleagues also don't have the same. So Youn, if you want to.
I mean, absolutely right. I think the US were first approved here, and then the EMA, the European Association, gets to look at. They have very strict criteria, especially using PFS, progression-free survival, which require like huge sample size. So it creates problems. But lacutamab, the French, you said it so well. It is a French developer, so I think that's going to be concurrent with EMA and the FDA. And that again, I forgot to mention in the phase of drug development, you can have a phase 2 level that goes to FDA approval. You don't have to always go to phase 3. Lacutamab would be an example where phase 2 will be going for a subset approval for Sézary because that's where the great activity is, and that will get accelerated approval in rare disease. But that accelerated approval is conditional upon a initiation of a larger randomized controlled trial that addresses the broader audience. And again, randomized control with an approved drug. But again, that's the kind of trial I think the European organization loves is and that's going to be progression-free survival, like a huge trial. It will take a while, which is kind of a shame because it takes so long for drugs to get approved, but at least it will be approved in the Sézary. But again, I think most are approved in the US. I would say mogamulizumab, right, is a our Japanese colleagues approved it for adult T-cell lymphoma leukemia. And so it was approved there and then came to the US for application in Sézary and CTCL. So I guess that would be another one that's approved outside that came to the US. Question about the JAK inhibitor, then I'm going to address the gamma delta question for Dr. Wang. But JAK inhibitor, you see the question, they were on it for 2 months, but then about infections. And we've had our spectrum of JAK inhibitor experience. Would you like to share our JAK inhibitor experience? You showed a great response, but not always the case.
Yeah, I think, when we learned about what drives these cancers, we thought very quickly that JAK inhibitors would be a good target. And I think we treated several patients with JAK inhibitors and found a very similar experience where many patients would have a transient benefit. And it turns out, I think for most patients, JAK inhibitors are very prone to getting resistance very quickly. So that purple cluster of cells is a good example. cells can become resistant and grow out of that a little too easily for CTCL. So by themselves, I think JAK inhibitors, we've stopped using many of the JAK inhibitors by themselves. There are some times that we'll use ruxolitinib, the one that we showed there, especially kind of earlier. And also, if we think that it's a mutation that's really fundamental to the cancer that it can't get around, then like an early mutation that is in all the cells, then we'll use it more. But I think JAK inhibitors have been one of those examples of a great hope for personalized medicine that really didn't pan out.
Thanks for that candid statement. Now, the gamma delta question is a very important one. And as Dr. Wang, Erica Wang said, the T cell receptor is alpha, beta, gamma delta. And usually MF is alpha, beta protein, TCR protein expressing, but there are some MF ordinary, you can't tell them apart visually. They have the same kind of skin lesions, but you biopsy and it shows a gamma delta expression. But otherwise, they're just like any other MF patient. And then there's patients where it's like more aggressive. Now, this subject is going to be addressed at the WHO, the classification group this year, because even the experts are confused. This is our biggest debate. How do you call something a delta expressing MF versus delta expressing aggressive cytotoxic T cell lymphoma, where you often have to go to allotransplant sooner than later. So we don't want to overtreat the delta expressing mild disease and not undertreat the other. So I think there's going to be some guidelines. And wanted Dr. Wang, if you have any, Erica, if you have any comments on, you see a lot of patients, again, we all see a lot of patients with the delta expression, how you would distinguish the two and the comments of how you would treat them.
Yeah, great question. I think the distinguishing part, clinical behavior, how it acts, how it looks, that makes a lot of difference. I have some patients who are delta positive, but they're all patches or a single patch. And it's been stable for years. So obviously very indolent, very slow, easy behaving. And then I have some patients who within a few months from a plaque turns into a tumor, and now it's ulcerating. And it's like 4 centimeters or 4 inches wide. So I think behavior plays a big role. And then the other thing, of course, is the biopsy, seeing certain markers, maybe we do a lot of genetic testing with our panel here at Stanford. So certain mutations may be more aggressive than others. So if we see those. And then treatment-wise, I think it depends again. I think if it's indolent behaving, we treat as MF. So things like phototherapy, topicals, depending what's appropriate. And then for the more aggressive gamma deltas, then we like to go for systemics to start off with.
Mm-hmm. Jennifer, or Michael, any added comments about this heated discussion topics at meetings?
I mean, I'd agree with, sometimes it's hard to really definitively classify these and put a label on it, even though that's what we all want. We all just want to know what to call this disease, but a lot of times we do just have to go with how it's behaving clinically. 'Cause certainly, like you said, Jen, don't want to overtreat things that are going to be mild and haven't progressed in 5 to 10 years, that someone's had a very flat rash, but don't want to undertreat or misdiagnose someone who's rapidly progressive and certainly needs more aggressive treatment. So I think, again, kind of just taking those things all into context. There's not a great single test that can tell us exactly what it is. We have to put all the pieces together.
I mean, no doubt under the microscope, the aggressive ones tend to have a lot of the cytotoxic markers, but it's never perfect. We've definitely seen patients who have a lot of these cytotoxic markers that also have very indolent behavior. And we always say, hey, this came up at a USCLC expert tumor board too, same topic. Is that when do we transplant somebody? And it was a young patient. And we always say, we can always take them to transplant when the disease declares itself. So when the behavior becomes more aggressive, obviously we would clear the disease with treatment and do an allotransplant, but we don't want to expose them to allotransplant unless the need is there. So I think that's kind of how we tend to approach based on the biology. I think that actually addressed all of our questions from the audience, and I'm still very grateful that we have the opportunity to share our experience with the patients, audience, and thank you.